Hi, everybody. Good afternoon. This is Joy from Strong-Hearted Native Women's Coalition. I have Michelle Shores from Palomar Health joining us today to talk about the SART process. Michelle, I'm going to have you say your credentials because I don't want to mess anything up. I know that you are very well informed in all of this. So I'm going to turn it over to you. And do you want me to turn my camera off? I know some people want it on because they don't like talking to themselves because you don't see the guests in this format. So I'm going to let you
Right.
decide.
I think that it's up to you, whatever you're comfortable with, Joy. You and I've had the pleasure to do this presentation for you for your conference over a few years. So whatever you feel comfortable with, we can roll.
Okay, I'll probably turn it off so that I don't just, have to have, that face of looking like I understand.
Sure, sure, no
So,
problem.
okay. I'm going to turn my camera off. We are recording. We will place this on YouTube for anyone that misses it. And thank you, Michelle. And I'm going to turn it over to you.
All right. Well, thank you everybody for having me today. And I want to, just start by saying that um, uh, I appreciate every year. I feel honored to be asked to speak at this conference. And some of you on the line might have heard me talk before or not, but I hope overall you learned something today. And you know, I think the thing is who am I and what am I here to talk about? Kind of an overall view of the process that happens in our county, in San Diego County, and it can mirror other counties. But so I'm a nurse by trade. My name is Michelle Shores. I have the pleasure to lead a team with Palomar Health here in San Diego County. My background, gosh, I'm getting old in nursing years. I'm joking about this, but I've been a nurse almost 17 years, and um, and it's gone by so fast. But also, what do they say about kids, right? The days are long, but the years are short, and so I love being a nurse. I graduated from Southern California, or sorry, I grew up in Southern California, graduated college from Southeast Texas. I practiced in Washington State for most of my career as an emergency and trauma nurse, night shift, where I also have been working as a forensic nurse examiner. So I'm a certified nurse, emergency nurse. I'm also a certified sexual assault nurse examiner for adolescent, adult, and pediatrics. So when I kind of joke that what all these letters after my name, what do they mean? You know, at the end of the day, at the bedside, people just want to know you care about them. And my biggest thing is I love being a nurse, but all the other credentials are really to assist in publication and in court or and whatnot. Um, and so again, I look at myself as a convener and a community partner and a mom. Who loves doing this work and caring for our most vulnerable populations. So I start my conversations off with, let's talk a little bit about trauma. And I think that trauma is a spectrum, right? It's how you, like, what is your experience in the trauma, and what does that mean? So trauma is injury, right? So when I talk about, oh, I was a trauma nurse, well, I essentially was a nurse that cared for those who were injury and a level, and in the field, it means like in the culture enough to where they've had a trauma that warrants a special team, right, physically. But I also kind of like to make this relatable because, right, trauma is physical, psychological, spiritual, it may be generational, emotional, cultural. I mean, trauma is really injury, and it's a whole, it can affect a person holistically. So when I think of trauma and in my day-to-day work, yes, I do come to work to hear the worst of the worst that maybe people do or experience to each other. But I also like to say, like, I have two boys, and my it kind of came to me one day when I was looking at my child, riding a bike. So riding a bike, has a helmet on, has everything on to protect himself, and he's just trying to enjoy himself riding a bike. And here's mom kind of watching. My child falls off that bike, right? Falls off that bike and happens to get what we call an abrasion or scrape to his arm or his knee. And in the most simplistic way, right? So trauma being physical, he just by shearing mechanism, falling off that bike, scraping his arm, that's physical trauma, right? It has caused an injury, which causes then pain, which, it also is emotional. Like, I'm just did not expect that to happen. And how is he responding? He's learning to respond. So I'm sure, he was crying. And so how do I then kind of intervene to help comfort him? One, address that physical injury. Does it need, and what's the top priority in this moment? So knowing as a healthcare provider, okay, this scrape is not something that is life-threatening, but to him it's very painful. So, acknowledging that physical trauma. Two is, how do I comfort him to kind of and empower him to let him be okay to have that emotion. Let's talk about that trauma. How is mommy going to address that? So I'm co-occurring caring for that emotional, physical, like, trauma in the spectrum. But I also, at the end of the day, want to give him the opportunity to empower him to get himself back up and be okay riding a bike again. Now, does that mean that he's not going to be more cautious? Does he not mean he's not going to remember that experience? No, like, this is his experience. But how does my intervention as a mom, or along with his brother and his dad, allow him the chance to get back on that bike, right? And so I guess in a way I wanted to bring this up, because when we talk about trauma in the space that I'm talking about, it's kind of that same concept. The difference, right, is that normally this is something that has an outside person has caused this damage or caused that trauma. And again, it's really about how do we as a team and a community respond to that trauma in the most efficient way. And I think a team approach is important, because one, when I look at trauma and I give that example of my son, just to say that it can be trauma is trauma, but how is it in the spectrum? So in my work, it's really important that I focus on the medical piece, and then I have my advocates that are my partners working with the patient for that social emotional concept. And then, we have law enforcement engagement working on protective factors, if child welfare is involved, if, mental health is involved. It's really about how do we work together as a team, I think, to give that the most holistic approach to heal. And so Palomar Health, when I talk about our services, I kind of talk about it in these different branches. And I'll go into this a little bit more. We have, these multi-layer systems that we use the team for. So our child abuse program, or our child advocacy center, is nationally accredited and has been serving children since 1984. Our sexual assault response team has been serving adults in the community since 1991. And then our medical evidentiary exams for domestic violence and other crimes or other traumas other than sexual assault started in 2017. And I also have nurse practitioners out at New Alternatives in Vista that will, when a child is removed from the home, they will perform the medical assessment to make sure that that child is safe for placement. But trauma in itself doesn't only impact our patients. It impacts our community, it impacts us. And for those of you that are on the phone today, I think the biggest thing is realizing that trauma is something that happens with our exposure, with our exposure to the trauma. So how do we do this work? It's really about, I really look at it as about my perspective. I have to be the best version of myself when I go in. And this is not my story. Does that mean I don't care? Absolutely not. I care a lot, but also I've learning that ability to really listen in a different way and to really be open and coming at every situation in that neutral fact and neutral stance in how am I listening without myself engaging and being emotional to this or reactive to this allows me to be the better caregiver. But does that mean at the end of the day that these stories don't affect you, that cumulative exposure? Absolutely not. So really, looking at vicarious trauma for healthcare providers, secondary trauma, burnout, how do we mitigate that? And a lot of that is prevention. A lot of it is being able to have a team member that you can debrief with, being able to really from a system level, promote healthy lifestyles, giving your team and say, to celebrate your successes, look at opportunities to improve. It's really all about how do we protect ourselves? Because trauma, it's different for everybody. So I have this link. I'm hoping it works. If the sound doesn't come on with this video, I will send the link to Joy and she can put it in the chat. But let's give it a try. Joy, will you just let me know if you can hear this?
I will let you know.
Okay. If not, I'll talk about it and let the team look at it.
I can hear it.
We need to take a statement so we can establish what happened on Saturday.
Michelle, turn your sound up just a little bit.
What time? I don't know.
Can you give us an estimate?
I don't remember. Would your pal remember what time you left the club? He seemed nice. She didn't remember much, did she?
I know. I know we've got to waste more time on a daft lecture. We know how to deal with victims. We've had years of experience.
Well, some of us have had more years than others.
I'm in my prime, I'll have you know.
That'll be right.
Today's session is about trauma. The latest in brain science will help you in your work. I'll start with a tour of the parts of the human brain. The reptilian brain maintains basic bodily functions. The limbic system is also instinctive. It deals with fear and pleasure. For example, you pat a dog, it senses pleasure, and without thinking, wags its tail. The neocortex is the site of logic, imagination, planning, and control. It's more sophisticated, but because it's conscious, it's slower than the older parts of the brain. The amygdala is a key part of the limbic system. It has one job, to sense danger and set off the alarm. When it's a matter of survival, the primitive parts of the brain override the conscious part. There are three possible survival responses: fight, flight, or the one that people don't think of, freeze. When the alarm goes off, blood and oxygen are diverted to muscles, adrenaline floods the body, and all systems that are not crucial to survival are switched off. Normally, the job of the hippocampus is to file memories so you can retrieve them later. But in times of danger, it stops filing memories, which makes it harder to gather evidence later on. Instead, the hippocampus switches to pumping cortisol. What's useful about cortisol is it stops us feeling pain, so we can focus on survival. Can anyone give me an example?
A farming accident where a man carried his own arm for a mile without feeling any pain?
Yes, excellent example. It is an evolutionary safety mechanism, which is fast and instinctive. In essence, it's our body's very clever way of protecting us. To recap, an example of the three parts of the brain working together. You're standing at a bar. Your reptilian brain is keeping your heart beating. You're enjoying the pleasure of a nice pint with your limbic system. You're using your neocortex to work out if there's time for another before the last train. What could happen to make the amygdala kick in? What if this happened? The way you'd respond would depend not on your logical brain, but on your instinctive brain. Being glassed in a bar would be a traumatic experience. Who can give me another example of an event that can cause trauma?
War?
Rape?
A car crash?
Good, yes. Trauma occurs when a person is overwhelmed by something beyond their control. The survival brain takes over the rational brain. It can lead to post-traumatic stress disorder, PTSD, with symptoms that last at least a month. Vicarious or secondary trauma is something you may experience if you deal with incidents such as rape or sudden death, or think of Lockerbie, Dunblane. You're not superheroes. Having a brain makes you all vulnerable to secondary trauma. It's important to understand that when trauma occurs again and again, it can become complex PTSD, such as in domestic abuse or child sexual abuse. The alarm system in the brain becomes jammed. Memories are stuck in the limbic system, so a trigger can set off the alarm. The trigger could be anything: a colour, a smell, a sound, a sensation. Now, the indicators of trauma. What should you be looking out for?
Depression. Crying a lot?
Yes, that's one response. And at the other end of the spectrum, total numbness.
Nightmares? Flashbacks?
Stress.
Good, yes. And they may feel sick. Also, shame, feelings of guilt, inability to enjoy sex, social isolation, triggers. People often feel overwhelmed by the symptoms of trauma. This can lead to using alcohol or other drugs to block out memories, or self-harm, or dissociation when a person's mind detaches from reality. Indicators can be specific to the type of trauma. Say, dental problems, when someone who was orally abused avoids going to the dentist. A victim of abuse might bond strongly to her abuser. This is known as traumatic bonding, or Stockholm syndrome. And jumbled up memory, when a person's normal recording of memories doesn't work. Can you recall any times you've seen that symptom?
What time? I don't know.
A traumatized person may not seem like her usual self, or may be hypervigilant, on edge, or being startled by everyday things. Everyone is different. You never know what impact trauma will have. Symptoms can change from day to day. So what does all this mean in practice, in your job? A traumatized person's brain is protecting them, but that normal human response of self-protection can get in the way of evidence gathering. The US military has developed new trauma-informed interviewing techniques that you can use to work around this. Research shows that if someone seems vacant, they could be distracted by their traumatic memories. Try to ground them by asking a simple, non-patronizing question such as, "Are you thirsty? Do you want a glass of water?" This can help bring them back to the here and now. Don't expect a logical, linear story. Ask, "What can you recall just now?" Find out what the victim physically felt or saw. Working this way, from the instinctive sensory parts towards the logical parts of the brain, you'll get more results. In conclusion, 4 things for you to take away. Trauma response is the brain in survival mode. Repeated abuse can make trauma symptoms worse. In response to trauma, people will behave in unexpected ways. Remember, trauma is a normal human response to abnormal events.
We know that you've gone through a really painful experience, but we need to take a statement to understand what happened on Saturday night.
Are you able to tell us anything that you remember about his flat? Anything at all? A dog barking.
Are you able to remember any physical sensations or feelings that you had?
Cigarette smoke. Can smell it now. What was going through your mind?
I couldn't understand it. I just couldn't move or even scream.
To freeze is a perfectly normal response. So you start with the memories, you don't start at the beginning. You have to engage with our feelings to get to the facts.
Makes sense. Check you, Professor, getting all sciencey on us.
Well, if it gets us usable evidence.
There's life in the old dog yet.
Aye.
So the reason I wanted to start with that video is kind of, again, bringing back to why do we do what we do, and it all is how we as team members and partners are responding to trauma, right, at various levels. And you know, I also want to say that you know, some of the stuff that I talk about may be difficult. Please feel free, and again, this is having kind of these hard conversations. But if you need to walk away, or if you guys have any questions, you know, please let us know. So as we've, you know, how do we respond as a community? So one is we talk about the hard things, we talk about it, but I also want to make sure you guys understand you know, again, trauma is a normal response to an abnormal event, and it has multi-layers, but very specifically around the sexual assault, child sexual abuse, child abuse. Can you see my screen again, Joy? Did it come back up?
Yes, Michelle, I can see it. Thank you.
Okay, perfect. Is this community response, or this multidisciplinary team response? And April is Child Abuse Awareness Sexual Assault Prevention Month. And this is the month where we talk about these hard subjects. We open these conversations because, you know, statistically, violence affects 1 in 4 people, in both domestic violence and sexual violence and child sexual abuse. And that's just what we know, right, based on CDC statistics and who, you know, may have reported. But, you know, that the bottom line is this it not only direct victimization, but also secondary victimization. So when I kind of talk about our services, again, going back to how we chose to respond to child abuse, how we chose to respond to sexual assault, I'm going to use a lot of acronyms today. And you know, I wouldn't be a true healthcare provider if I didn't give some acronyms, and you know, hopefully everyone has you know, if you have any questions, let me know. But so we kind of, again, have these 2 branches of services. One is how we respond to child abuse, and that is really very specific through our Child Advocacy Center. We have, and I'll talk a little bit about that, but also our medical evidentiary exam. So that the medical evidentiary exam is a consent-based process that allows somebody to come forward and have documentation of the abuse. Child Advocacy Centers is really that coordinated response on how to minimize how many times children are talked to, because we want to make sure to really bring all the professionals to the child and also to our patient. And I'm a nurse, so I use patient a lot. If you're in the mental health or advocacy field, you might use client. Law enforcement may use the term victim. And then, you know, we have that victim to survivor to thriver spectrum. But really, it's all about our person and our person we're caring for. So we have the medical exams 24/7, child advocacy, and the trauma response, or the TRC. So what is, let's see, what is a CAC? So a child advocacy center is really, it's a coordinated response to dealing how we handle abuse. And you might have also heard of a family justice center. And that is all really this core concept of having this one location that somebody can go to receive all the services, and the partners and the disciplines come together. So let me go ahead and share a little quick video on what is a child advocacy center, or CAC.
A Children's Advocacy Center, or CAC, provides support to victims of child abuse. Without a CAC, an abused child may have to tell their story over and over again in settings that may be scary or where kids may think that they're in trouble. Then, families have to search around for the services their children need, all on their own. But in a CAC, a child tells their story to a trained interviewer who makes the process gentle on the child and finds the facts which are crucial to the child's case. Then, a community of professionals in medicine, law enforcement and child protective services, prosecution, victim advocacy, and other heroes work through the CAC to decide the best way to help the child. And CACs provide science-backed mental health care that heals kids from trauma and helps them reclaim their futures. This community of caring professionals rallies around the child so children have everything they need, all in one place, at the CAC. To find your local CAC or to sign up for updates, visit nationalchildren'salliance.org.
So in order to be, and so in San Diego County, in order to be a child advocacy center, you have to have 10, follow these 10, you have to all of these services, and all of our services are at no cost to our patients. So we have.
Good afternoon, everyone.
Oops.
Brian Boston.
Oh, sorry.
For National Children's.
I apologize. I left the video going. You know what, Joy, I have to say, there was one time I was giving a presentation and forgot to turn it off, and then we were listening to Tina Turner Rolling on the River. So apologize. I was like, oh, someone had a question. Yeah, no, it was interesting. So in San Diego County, I think I want to make sure I have the right view. Okay, so the child advocacy centers are with Chadwick and Palomar. So those are really those two specialty locations. There's two in our county, one for North and one for South, offering all the services. But for our medical evidentiary exam for adults, for sexual assault exams or DV, our department is a centralized department that covers the entire county of San Diego. And so we keep 3 nurses on call 24/7 to manage all of the cases that we have. And so I just want to make sure, we have these core locations. We're going to be located in North at the Family Justice Center that's going to be opening at One Safe Place here soon in June. We have a location in Poway, and we have downtown at Your Safe Place, the Family Justice Center. We also, our medical team is cross-trained to see both adults and children. And that's a real specialty training to perform those exams. We also have an community response. And so I just want to pause, Joy, and say, does anybody have any questions right now?
If you have questions, go ahead and either raise your hand or you can unmute yourself. You have the ability to do that. Or you can type it into the chat and we will see it.
No.
No, I'm not seeing any hands raised or anything typed in, so.
Okay. And yeah, okay, perfect. So let's go ahead and keep going. So, I mean, how are we on time, Joy? We still have some time, right? We've still got a while. So I want to we have about an hour and 20 minutes, right? So we're good?
Correct.
Okay, perfect. And I think that I wanted to share this little video with you all. This is of our old location, but I wanted the reason I wanted you to walk through, especially for those of you performing advocacy in the field, or how do you maybe, if you had somebody who presented and was asking about how do I get an exam or whatnot. So there's different layers of kind of services in our county. One is if somebody needs health care, if they need to talk to somebody, they can, of course, go to a hospital, their doctor's clinic, whatnot. But those those entities or general healthcare does not really do the specialty type of exams that we do in our department. So our department does not give a patient a bill for anything. Now, I do have to just state that we live in the state of California, and so most of anything with sexual assault, child abuse, domestic violence is a mandated report. Nothing requires somebody to participate, right, if they're an adult, but from a healthcare perspective, we do have to submit a report to law enforcement, and it's usually minimal information. And that's really kind of in that general healthcare sense. If that patient would like to have an exam where they want evidence collected, photos, access to the medications, that itself, we talk to the patient really a lot about that, and we do that in partnership with advocacy, and usually if they would like law enforcement involved, but they do not have to participate. We do have to notify law enforcement of what they call a suspicious injury. And most of our services do not require somebody to go to an ED. So if we had someone in the county or really in the state, anyone who, if there was a sexual assault for an adult, within 5 days, they may seek an exam. They do not have to go to an ED in our county. They do not have to go to the doctor's office first. Our department will perform the full exam for them at no cost, where we take really a focused history. We take in their own words, we really use that open-ended trauma-informed approach. This is a consent-based exam. So in the state of California, those that have experienced sexual violence or intimate partner violence may seek healthcare or a medical evidentiary exam from the age 12 and older in the state of California under Family Code 6930. And they do not have to have their parent, no one can force anyone to have this exam. No one can coerce anyone to have this exam. The exam itself is a consent-based exam, absent a warrant from law enforcement. So in general, sexual assault without significant, and I mean this from a medical perspective, if there has not been strangulation, head trauma, major injury, most of the patients do not need to go to the ED. So really, that sometimes it removes a barrier. So most of our departments are outpatient departments that are private, do not require anyone to go through the ED. We manage all of this in-house. We provide the medications. But I wanted to give you just a quick little walkthrough of what a clinic like this might look like. So if you see a patient, you could explain to them, hey, it's a private center. We don't have to go to the ED. Now, I will use the caveat, this is how our county is built. Not every county is built the way we are, but most are. And so this is just a quick little walkthrough of what it would look like coming to one of our centers. And this is showing for really around the Child Advocacy Center, but it also crosses over to the space for adults of where they would, like what kind of environment they would be coming into one of these centers.
The Palomar Health Child Abuse Program is a nationally accredited child advocacy center by the National Children's Alliance. Our Child Advocacy Center is located at 141 North Fig Street in Escondido, California. And the designated service area for our Child Advocacy Center is North County, San Diego. The Child Advocacy Center is currently located on the Palomar Health downtown campus, easily accessible from Interstate 15 and Highway 78. There is adequate parking, including wheelchair accessibility, located in the back of the buildings. When patients arrive to the CAC, they enter through a secure glass atrium that connects the two buildings. Patients then enter the center lobby, a child-friendly waiting area where there is comfortable seating, age-appropriate toys, and culturally diverse reading material. There is also a TV and age-appropriate videos. When families arrive to the center lobby, they are greeted by CAC staff, offered a beverage, and the clinical team will briefly describe general processes of their anticipated services. The pre and post interview gatherings will take place in the CAC conference room, where multidisciplinary team members and caregivers can meet and discuss the case in a private, confidential space. Multidisciplinary team members will then gather in the CAC observation room, where there is comfortable seating and a counter workspace. Our multidisciplinary team will observe the interview through a one-way mirror or on the computer monitor. The forensic interview is recorded using a high-definition video camera placed on a tripod and recorded onto our secure IVS vault system. Audio is received via speaker. Our Palomar Health CAC forensic interview room is small yet comfortable, a safe and neutral space where children can be interviewed. The furniture in the room can be easily arranged to accommodate children and adults of all ages. The forensic interview room is soundproofed and has a covert microphone system and wiring that connects to the adjacent observation room and is separated by the one-way mirror. We have an interpreter line or a screen that can provide interpreter services for both ASL and all other languages if our bilingual staff are unable to provide interpreter services. Our Child Advocacy Center has 2 medical exam rooms. One is prepared for the adolescent adult population and the other for pediatric patients. The exam rooms are equipped with supplies and state-of-the-art equipment such as SDFI secure digital forensic imaging camera. Acute and non-acute medical exams are conducted here. In our pediatric medical room, we have placed pediatric-friendly focal points such as this mosaic on the wall to make the room more comfortable for children during their medical forensic exam. Our Child Advocacy Center has a private single shower and changing room for patients who have undergone a medical forensic exam. Each patient is given a change of clothing and a toiletry bag that has been donated from a partner agency. The Child Advocacy Center has a designated area for evidence storage, including locked cabinets and a locked refrigerator that is temperature monitored. Each kit is picked up by the crime lab once a week to be compliant with local and state laws. Our Palomar Health Trauma Therapy Room is spacious and filled with developmentally and culturally diverse toys. The center has a designated area where we store emergency supplies or comfort items that have been donated by one of our community partners. The patient records room securely stores all physical charts. A secure forensic encrypted drive holds electronic patient charts as well. Our Palomar Health Child Advocacy Center is the only location in North County, San Diego that offers a soft room or a location to be utilized by Human Trafficking Task Force and advocates for victims of human trafficking or CSEC. The soft room allows a space for calm, trauma-sensitive interviews by investigators in a confidential manner. There are a total of 3 restrooms available for staff, patients, and families. We also have areas that are private for our staff to perform the crucial work they do as a team. Our Child Advocacy Center is a hospital-based program, and we follow all of the district rules and processes for safety. Our center in each building has designated exits, fire extinguishers, security radios, as well as defibrillators in case of an emergency. Our center has taken every precaution during the coronavirus pandemic to ensure the safety and security of our clients and partners entering the center. Posted on the door of our center, we have signs in both English and Spanish that communicate coronavirus safety precautions. Additionally, we provide masks and hand sanitizer to all that are going to be seen at our center. As a hospital-based child advocacy center, we follow the overall mission of our organization, which is to heal, comfort, and promote health in the communities we serve. More specifically, our Child Advocacy Center mission is to provide a foundation of healing and comfort while offering a trauma-informed, professional, compassionate, and coordinated approach to the care and evaluation of physically and/or sexually abused children, adults, and elders. Our Palomar Health Child Advocacy Center was established in 1984. Our vision is to be nationally recognized as the provider of choice for forensic evaluation and treatment, comprehensive assessment, trauma-informed victim services, abuse and assault prevention, and community awareness and education. We remember and honor those who started the program and who have contributed to its growth and expansion. Our Child Advocacy Center continues to grow and expand to live the mission and the vision that we have set forth. Recently, we have added additional adjunct music and art therapy to our trauma therapy program. It is our hope that all who enter this space feel welcomed. We are committed to providing trauma-informed services for all that enter into the space so they feel welcomed, heard, and they leave with a sense of hope.
So I wanted to share that with you all because I think it'll give you a little more of a concept. And this is an old video. I just have to give the caveat. And this is a center that we just moved out of last year, but the concepts will be rolling over to our new center. And this was really meant for our accreditation because we hold that accreditation for children, but the same principles and concepts go to serve our adult patients for both sexual assault and domestic violence. Because again, April is the month to talk about both all these issues and concerns. So we as a department, in 2017, we based on a survivor's language, as I don't know if you're aware, but there is a high-risk domestic violence team in our county, and we have done a really great job of addressing sexual assault and child abuse. At least again, there could always be more work done, but I think systematically have been able to really to succeed in how we respond as a community. Being part of the sexual assault response team, the steering committee, there's really this coordinated response. But for domestic violence, or intimate partner violence, there was this gap. And that's where we, I think as a system, looked at how do we make access more available for those that have experienced violence that did not have a sexual component. And where a survivor had stated in a meeting, this is what inspired me is really great. Everyone can help me change my locks. We can, do all these things, but nobody believes me. Nobody believes me that anything is happening. I can't go to the doctor. They don't either understand what's happening or he monitors. I can't take pictures with my phone. He monitors my phone. No, I wish that I had somebody who had documented what happened to me so I can, display that. And the issue came down to money, and it came down to one, there's systems in place for sexual violence and child sexual abuse, but there wasn't anything in place for our elder abuse, human trafficking, strangulation. And we know in our county that we have 17,000 domestic violence calls a year to report to law enforcement. And the domestic violence fatality review team has identified that over 22 years, domestic violence, about 13% have died by homicide, by strangulation, or by gun violence. And we know strangulation is an elevating form of violence and has a likelihood to increase somebody's lethality by 750%. After strangulation, they're 750% more likely to die at the next time. And also we know strangulation doesn't have a lot of visible injury. And this is where maybe in October I'd be happy to give like a more, you know, comprehensive, or coming to the cares, because we can have a whole discussion on strangulation. But strangulation is dangerous, and oftentimes it's missed in general health care, right? Because there's not these societal external findings that you expect to see. A lot of it is the subtle loss of memory, the subtle symptoms, voice changes, headaches, memory loss, and it sometimes gets missed in the general healthcare space. And I know, because I told you I was a trauma nurse back in the day, and when I'm looking at my patient load and I have a stroke, somebody like with a laceration, and I have a strangulation patient fell off my radar as being dangerous because they're walking and talking, when in fact that was probably the patient that deserved a higher level of attention, because what we know now is they're, one, more likely to die, two is strangulation can be vessel compression and or airway compression, and it takes very minimal pressure to cause somebody to lose consciousness and causes those effects that have a noxic brain injury. So we found a pilot program, and we added a forensic nurse in our county to see patients, give access to patients who did not have a sexual abuse or sexual assault. And that program has now set the model really for improving access, making sure access is available, and bringing domestic violence, elder abuse, and trafficking exams on par with access for sexual assault and child abuse. And then we also, in 2018, we added our own child advocates. We have our soft room, looking at how then do we train the community. So it's great that we have all these processes in place, but we really needed to come up with a training. We need to get this out to the community. So the CARES training stands because, again, healthcare respond to acronyms. It's about conducting screening, assessment for strangulation, reporting, evaluation by a forensic nurse, and safety planning and services. And then we also looked at, like during COVID, that was really challenging, and I'd have to give kudos to all my advocates for being virtual, but we had to figure out how we were going to respond during the pandemic. And our response as a county was published in the Journal of Emergency Medicine as best practice for sexual assault. We also have looked at, okay, we have this upfront response, but how do we care for people in a more comprehensive manner? And we've added some grant programs to provide no-cost therapy for children. We also have now just recently opened our trauma recovery center, which will be a no-cost short-term mental health system for all victims of violence, not just sexual abuse. And so I'd love to connect you with Dr. Debbie Zenga, our new manager, and she could probably come and tell you all about that service. But that will include, so we will be able to accept referrals now from community partners and provide no cost or grant funded short-term trauma therapy, to include potential anoxic brain injury and traumatic brain injury clinics. And then for children, also looking at this in a way of how do we bring, again, this holistic approach for children. We did really well on when there was an outcry or a disclosure, bringing that child for an interview, medical, and connecting to advocacy and mental health. But now we have created an external pathway for children who've experienced trauma to come in, for them and their families to receive short-term, no-cost mental therapy. And that includes the psychoeducation, it includes art and music adjunct therapy and case management. And not only after these short-term sessions, but we're also looking at continuing children in groups and how do we push further and maybe having Camp Hope, pathways, and trying to keep these kids engaged through the system. Here's just an example of the journal that we published if you'd like to learn more about that. Our department has also been instrumental in changing law, and we've put out through our programming, understanding that minors were not given the same right to consent if they had experienced domestic violence or teen dating violence versus sexual assault. So that was updated as a result of just by adding exams for other than sexual assault. We've sent out KHANs. We understand that the KHAN is usually seen for like Zika or a public announcement. Intimate partner violence, including sexual assault in our county, is seen as a public health problem. We've published workbooks. You know, and this is something just to, I think, for consideration of the community, and that's really not my focus as a medical professional. I want to make sure everyone understands I am speaking about working as this multidisciplinary team, but my role is that I am the healthcare provider in that team. I do not work for law enforcement. Advocacy has their very specific role. Crime Lab has their specific role. Our social workers, our mental health partners. So I think the goal is going back to that patient statement of like, I have no evidence, is looking at how just by having a neutral comprehensive report introduced to the process with the consent may allow a more responsible decision to be made for filing serious cases as felonies. And just in our short time frame, the felonies for violence-based cases has improved by fourfold in our county. So talking a little bit about CARES and what this means, this is really about creating a standardized process of how to address intimate partner violence, sexual assault, domestic violence in our county, especially in the healthcare front. So you can go to the San Diego healthcares.org to learn more about that as well. You know, this was a big training that we put out, and we're still continuously doing training on this every quarterly for healthcare providers. We've, you know, made awareness campaigns, we've set kits out. And this is, I wanted to bring this up because a lot of the times people will ask me, well, you know, exactly how many patients are being seen, and you can look on this from year to year. So in let's just go 2014, the forensic interviews, so these are child exams, and the SART is sexual assault exams. So, and then the DAFI is DV. So we had a total of 141 kids come in 2014. We had no medical exams and 100 sexual assault patients in the year of 2014. No DV, no therapy. Jump forward to 2021, through education awareness, we had 304 kids come in through our child advocacy to talk to our interviewers last year. We had 38 that got medical exams. Again, this is something that is still a gap that we're addressing. But look here, I mean, I will say, I'm going to talk a little bit about COVID, but in our county, we had 678 sexual assault patients come in and consent for an exam last year. We had 240 domestic violence patients last year. 18, what a fax is this is when there's no relationship. So maybe a strangulation, gang violence, maybe some other crime, and then children that are seen. We had 125 kids last year that got therapy through our new programming, and I look forward to seeing what the TRC will do for adults. COVID was an interesting dynamic in that it didn't stop violence. It just changed, I think, if you look at the numbers of sexual assault cases, so our DV cases actually went up, and I'll show this with you. But during COVID, and this is just a theory, we had about 100 exams less than normal. And was it due to the stay-home orders? Maybe there wasn't as much opportunities for acquaintance encounters or abuse, or were people afraid to come to the hospital because of COVID? But I will say, from my nurse's perspective, they felt that the acuity or the violence was higher, even though the numbers were lower. That there seemed to be just more intensity to some of the stories they heard during COVID for sexual assault versus before. And our child abuse cases went up. And so there really wasn't an issue with, there was a lot of concern that children were not reporting, but just looking at the data in our North County, like, we had more children reporting abuse. Now, is that because they were home and there was more stress and more abuse was happening? But, I think there was a lot of fear that the children wouldn't have access to report. But we did, have an increase that we saw that year in reporting for child abuse. And DV also increased. And we have, in our department, this is for sexual assault, we have, breaking down the percentage for 2020, we have about 53% that identify as white or Caucasian, about 35% as Hispanic Latino, 6.4% as African American or Black. We have 1.9 that identify or self-report as Asian Pacific Islander, 10% is Indian Alaskan Native, and 2.2 is other. And so looking at, and then undisclosed, nobody had not disclosed their ethnicity here. And we also looking at the ratio. So for child sexual abuse, it's pretty interesting, with adult sexual assault, you'll see here in a second, it's primarily female. We have about 1% male that come in. For child abuse, we have about 30% males, and the average age is 7 to 12. That we see is more than half. And we have about 17% that are adolescent and 32% that are under age 6. And domestic violence is, interestingly, like I said, I think I might have accidentally left that slide out, but sexual assault, about 1% of males come forward for an exam of the cases we see. For domestic violence, we had 12% of identified males that come forward. And so it's looking at the trends across the spectrum. Sexual assault seems to be consistent, that more males do not come forward, or we don't know, right? Whereas I think that's where a lot of studies come in of gender-based violence. Also looking at children in the home, if there's been an intimate partner violence, how do we intervene and get these children recognized as secondary victims and get them connected to services. And when we started, seeing children, we've identified them more through the home, through DV, and coming in for more services. You might see some people in here, this is pre-COVID. I have to give that disclaimer, where we got together and we did community outreach. We got together and we really, looked at how do we as a team come together and promoting and educating for our survivors and our patients and whatnot. We host a pinwheel ceremony every year, and we haven't been able to host the actual ceremony, but we have been able to still place pinwheels on the lawn. And so let me just talk a little bit about the pinwheel here, and then we can go in. I think I have another slide for if there, for more exam specific or for questions around the exam. But this one I might have to go to. But this is the pinwheel. And again, April being Child Abuse and Sexual Assault Awareness Month, we have we really take this symbolism to heart, in that the pinwheel in itself, the center, really represents the patient and in the center, and all of us as partners have to surround that patient to, you know, as team members. And if you think of the pinwheel, if there's a fan that's broken or out of line, the pinwheel can't spin. So really looking at this as planting hope and how do we, you know, how do we get this right? And with that being said, I have a video I'll close with, but I just wanted to do a check-in. Do we want to go in a little bit more about the exam or strangulation, or anything specifics, Joy, that you want me to kind of go into? Because I wanted to make sure to check with you guys and see how you're doing, if you need a break or if you're doing okay.
Okay, does anybody have any comments on that? Does anybody have a preference? I know I had one question in here, but that individual had to log off.
Oh no. Oh, what was the question?
Well, they asked what actions have been, and I think you kind of touched on it a little bit. What actions have been taken to help survivors feel safe to report? A lot of times there's a lack of evidence, so survivors are not believed and a judge doesn't rule in favor of the victims.
Yeah, and I think that's part of where, like, having the medical, because it's also very normal to be normal. So I will say that in general, we know that it's more common to not have injury than it is to have injury, right? So I think that kind of, oh, here we go. I think that knowing here, I'm going to pull up some of this exam, and I'm going to walk through a little bit about the exam here. I think that'll be helpful for everybody. I just had it on a different slide. So when I talked to, and I'll put this out there, I think it's, you know, looking at, here, let me go to this screen. And Joy, I didn't go into strangulation today unless you want me to, like more of the like physical stuff. I'm happy to, but this, you know, looking at California. So California is a complicated state, and I'll say this in all fairness, is we have a medical mandated reporting. And that itself can be, you know, I think that a lot of people fear that, but in reality, it can, I mean, it can be helpful. So we have to abide by, as healthcare providers, by the medical mandated report. And that's, again, that conversation. So advocacy, mental health does not have the same, do you see is my screen showing up again? You see that versus the forensic medical exam?
I do.
Yeah, so most of the time, so there is a process in place for California. We are a medical mandated reporting state. And in California, law enforcement is the authorizing party and the payer of source for forensic exams. But these are consent-based exams, and nothing mandates that a patient shall participate to have an exam for sexual assault. Now, children, you know, as you know, we're all mandated reporters for child abuse, and we cannot guarantee that a case will not be charged without their involvement. You know, so I think it's about how we educate ourselves. So for sexual assault of an adult, they may come in and have what's called a non-participating report. And that conversation happens with them where I have to tell law enforcement a very brief minimum information about your case, but you do not have to talk to them, right? You can elect to have your violence against women rights. You have access to this exam, and you do not have to talk to law enforcement. That does not negate the fact that I have to report the crime. But on that side, in California, all of the sexual assault kits are tested. They're taken so once we collect them, they're taken from my center into the crime lab within 5 days. The case number that we get from law enforcement is tied to that kit. That can then moves through the system and allows that patient and the survivor to track where their kit is using that case number. So I think it's about perspective of just sometimes like the current process is how we report it doesn't necessarily, it doesn't mandate that they have to participate, right? And so when we come from like a start by believing, that's really like what we're trying to do, and the medical exam, we are, again, that neutral party, that healthcare, and again, there may not be injury, and there may not be DNA. And DNA proves contact, right? It doesn't prove consent. So I think having the exam itself can be beneficial because we can speak on behalf of what we found through our medical evidentiary assessment. Having advocacy there, especially with law enforcement, if they want to have an advocate present, they have that right for any interviews, and really looking at it, every case will be different, but how do we up front have that systematic approach to give everyone that equal chance? So in our county, if somebody does not want to participate with law enforcement and wants an exam, we have to follow certain guidelines, which means that if they want an exam and they're an adult, an exam is not going to help them after a week, right? It's really about within that first 5 days after the encounter, where we have the ability to take those photos, to take that history, to collect potential evidence, because we don't know what we're collecting often. We collect based on history, and it gets sent to the crime lab. And so their best chance is within those 5 days after an assault. After that, they may get medication, but there's a time frame. So let me walk through this. So I don't know if that fully answers your question, but from our perspective, we take the approach of, for sexual assault patients, access to an exam is important, and they have that absolute right to have one, whether they are participating or not with a law enforcement investigation. And sexual assault patients have that ability under federal law and California law to have access to an exam and do not have to participate with law enforcement, if that makes sense. Did that answer your question? Or
they've logged off, so
okay.
I'm going yes.
Okay. Well, I guess the access doesn't change for anyone if they want to participate with law enforcement or not. They will still get the equal access to our care and an exam. As long as it's, again, we can't do this outside of the time frame. So if it is with 8 or 9 days, that may not, that's not something that we can really, this exam does not benefit them, right? And so that's where understanding what it is. So you've seen the center, we've talked about trauma, we've talked about all of these things, but what do we actually do during the medical exam? So one, how does a patient get to us? There's those two pathways, and we're going to talk adult sexual abuse, sexual assault. Is they may come to us through law enforcement calling and authorizing. At that point, we call the appropriate advocate, and we all meet at one of those centers. When we meet at those centers, if law enforcement's involved, the nurse gets a brief brief history from law enforcement. We really don't get a lot. We get some paperwork signed. We give our advocate an opportunity to meet with the patient prior to the exam, because they clarify their role. And then we come in as a team and we sit around that round table. We sit together and we talk about, and we have that conversation about the exam itself. We go over the fact that, you know, Joy, you are the confidential advocate. I'm a nurse, so I'm a medical mandated reporter. So I just want to make sure you understand that everything we talk about today, I do document, and it will, you know, will go to law enforcement. So we really have that very upfront conversation in the consent process. We talk to them about the fact that this exam is conducted at no cost to them. They will not receive a bill for any of our services today. And it's at public expense. You know, I'm going to explain to you what this exam is, and you can say yes or no to any part of this exam. This is something that you have the power to make these decisions. And although I may feel something's important, I'll explain it to you. You get to say yes or no. And this exam consists of, I'm going to get some general medical details. I just need to know a little bit about you. I'm going to ask you to tell me in your own words what happened today. And then we're going to go into some clarifying questions. Then from there, based on what we talk about, we'll take you to the exam room. You know, Joy, I'm using as my advocate. Joy can come with us, you know, if you choose, because we want to make sure they have a support person. And when we go in the room, I'm going to look you over head to toe. I'll be taking some pictures of you with your clothes on, with your clothes off, and of the genital region. And we'll walk you through the process. I'll also be collecting some evidence, which is sterile swabs and sterile water or Q-tips on your skin or in your genital area to look for DNA. I clarified that they know what that means, and then we talk about that I won't know what we collect today. However, I'll send this to the crime lab and they'll be testing it. And then I also talk to them about that we will offer them a shower, we'll give them clothing, that they'll have time to meet with their advocate afterwards if needed. We provide, based on the history, if they're within 72 hours, we provide non-occupational exposure prophylaxis for HIV medications. So we will give them, it has to be within 72 hours of the contact, and there's really strict guidelines on who gets it and where we get it. So based on that history, we will offer, and we also we give them their first dose, a starter pack, and we work to get them their full monthly dose. And we talk to them about the medications, because those are really time sensitive. And just for awareness, taking HIV prophylaxis medication is so crucial that they take the pill every day for that month, or else it's ineffective. So if they take it for 15 days and forget their dose, it's like they never took the first pill. So we really have to have that conversation with that patient. That's really important medically. We're also looking at if they've had strangulation or other mechanisms that require an ED visit. We're talking to them about why we're concerned. We also provide other STI, which used to be known as STD, but it's not a disease, right? So previous language was sexually transmitted disease. We now refer to sexually transmitted infection. So we provide prophylaxis. For adults, we do not test. The only testing we do for sexually transmitted infection is if they receive HIV medication, we're going to do a baseline hepatitis, syphilis, and fourth generation HIV panel, just to get a baseline, right? Because we want to know, have they been exposed prior if we're giving them these medications.
Michelle?
Yeah, go ahead.
I have a question. So I just had someone ask, when the full body photos are taken with and without clothing, is the head and the face included in the photo?
No. So what we do is, the process is we do what's called a book-in photo. So we take a photo like of their name, kind of, it's like a series, right? And so you start your series with an identifier, just like in any medical process. We do take one overall photo view next, and then we only take bodily photo. So we may take clothing if they have assault related clothing on, right? To make sure if there's rips or tears, to kind of give that view before we take them, before, you know, we package the clothing. But the only time we would take photographs of bodies is if we see injury. So we don't just take pictures of the body unless there's injury found. And in that case, you would isolate that area and you do a photo series. So let's say somebody has a bite mark on their arm, right? So the examiner would place that patient in a position and you kind of do an overview, because you have to be able to identify the location in your photo series. So we would take an overview of that injury on the body, and we move in closer, and then we use measurement tools. So if that person had no external injury, that facial photo would be the only photo. But the caveat to that is, for genital photos, those are standard photos that we take in a series, because the injury can be so microscopic. Sometimes the only way to review it is on the camera. So we walk that patient through that, but they do not have the face in them for body photos. And if that makes sense. I hope that answered your question.
Thank you. I think it does. Yes.
Yeah, it's a very, you know, the examiners have a lot of training around the photography, the process, and we are working with that patient at every step of the way, you know. And again, they can decline at any point, and that's okay. And you know, but those photos are so protected. They do not, nobody can get them. They only go to the process, and usually the only one who determines what can be used or not is a judge. So these are not accessible photos to anybody. They are separate than just general medical records. They're very protected. And so from there, you know, we go through the medications we offer. And the reason I wanted to come back to the STI medication. So we provide prophylaxis for pregnancy exposure. So we can provide medication up to 5 days for post-exposure for pregnancy and STIs. The reason we do not test adults for like gonorrhea or chlamydia is if they've had an exposure based on that assault, they will not convert generally to have gonorrhea or chlamydia within 5 days. So really the testing is irrelevant, and it's at this point. So the best thing to do is just to treat prophylactically, and then give them the guidance, and for them to have follow-up with their provider or the clinic. So it's, you know, really about focusing on how to provide that best treatment and protection. So again, all those medications are available to them. And then, you know, we work on follow-ups for mental health advocacy. If advocates there, they're, you know, really going to be connected into services. And then the nurse at that point kind of goes to work. So again, like I said before, this is all consent-based exams. We use standardized forms. We go through a standardized history. There is never anyone that can mandate that this happen, or the patient is the one driving the bus here. We do ask, you know, a lot of questions, because again, it's just providing that standardized procedure based on their history, or if they have no history. So if there's no history, but they have a concern that something happened, we have a standard set of collection. For our kids under the age of 12, we do not ask them any questions, really. No direct questions to children under the age of 12, because they cannot consent. 2 is we want to try to get them in for an interview, but we kind of go through this standardized exam and don't ask direct questions to children. So they will come back later to talk to the interviewer, as you saw, using non-leading evidence-based open-ended questions versus to hear them in their own words versus us asking direct questions. But for adults, you know, we will collect oral swabs, buccal swabs, if there's any specific areas that have potential saliva, if they reported being bit, spit on, and really, you know, and clothing can be very important. We don't usually take people's shoes or socks unless it's necessary. Generally, it's going to be the clothing that either came in contact with the person that hurt them, or they're reporting hurt them, or has some sort of evidentiary value. But again, we provide them with clothing at the end, and they do not normally get that back unless it's deemed irrelevant. And sexual assault kits are always tested, and they are not destroyed in the state of California that I'm aware of, at least prior to 40 years. So, you know, like I went through, they arrive, they meet the advocate, this is support. The exam itself takes about 2 to 3 hours. So the history is about an hour, the exam's about an hour, and then the after, you know, care can take about half hour. So overall, we're trying to get them out sooner. But for us, you know, at that point, we are going to be, it takes an hour to dry the evidence, packaging the evidence, and so on and so forth. We look at injury identification. We're very specific and enforce. So again, when I worked in the ED, we call everything a lac. You slice your hand open with a box cutter, a laceration. But in fact, speaking specifically as a forensic examiner, a laceration is a blunt force injury. It's caused by something blunt or you know, on that surface. An incised wound is actually caused from a shear force or something like a knife or such. So when we're looking at these injuries, we're really looking at it in a lens of, if somebody states, I was pushed from behind and I fell forward, you know, when we look at the patient, we're looking at, okay, what did they land on? Their hands, we're looking on their knees, we're looking at areas of their body that would have come in contact with the surface. And then from there, we're looking at, is there gravel, is there grass, and we're describing it, right? It's not up to us to make the determination of innocence or guilt. That's up to the court. Our role is to really listen to that history and look at, does the mechanism match the history in some level? And that's where we can speak to it. And if they said they were pushed from behind, do they have marks on their back, or is there some sort of tenderness? You know, what is going on? But if there is an injury, it will be, we'll photograph it. We do not photograph areas that do not have injury, tenderness, or swelling. And I will tell you that there is no scientific way to age bruises at all. Bruises are on a spectrum. So if you ever hear anybody state that's a fresh bruise, it is scientifically impossible to date a bruise. And I always joke that one of the medical examiners that taught at my program up in Harborview, he very, very dry personality, but I remember one thing he said in my training, and he was like, don't date a bruise, they make terrible dates. And it was funny to me in a way, like I didn't understand at the time, but now, you know, I think we have to look at the only color that is medically consistent with time is yellow, is at least 18 hours old. And yellow, and the reason is when the bilirubin starts to disintegrate, when we have that response to kind of our heat, when we hit our, let's just put this in example. If I was to hit my thigh on a table, and I've had this happen where I'm like, oh, that hurt, and I don't see anything, but a couple days later, I might start having a bruise come up. You know, that it happens. If somebody was to look at that and go, oh, that's a fresh bruise, I think that's irresponsible. But if I start noticing that yellow, I know that happened at least 18 hours old, because when we hit our tissue, our body's normal response is to protect itself. So it starts sending in all the white blood cells, red blood cells, right? If there's vessels that were burst, you know, we kind of get that leaking into the tissue. And as those red blood vessels start to, if they're moved out of the veins into the tissue, they start to disintegrate because they can't regenerate themselves outside of the veins, right? So they, as they die, they break open and you get that kind of yellow. So I just be cautious on bruising, and medications, age, and a lot of things can change that. So we will never speak to the age of a bruise. All we will do is describe it. We take series of photography. This is just an example. Using one of my staff members, what maybe a series for strangulation may look like. We're looking at, you know, areas in neutral, lateral side and rear positions, also looking at the mouth, the eyes. I didn't put the close-up of the eyes in here. You know, this is just an example of what we might take for strangulation. We even get even closer to the eyes. We're going to be looking in the mouth. We're going to be looking at all the frenulums. We're looking at all the areas. We're looking at the hands. We're looking for broken nails. We're looking for whatnot. The other thing too, I just want to share is this next photo is we talked to that patient about if there has been strangulation, it's really important we from the medical perspective understand how it happened, because you do not need airway involvement to lose consciousness. You can have vessel involvement. So depending on how, where, and when the pressure was applied, we ask from the medical perspective for if someone's willing to describe or point to a photo of that most represents how the pressure was applied, so we understand from the medical perspective what we might be thinking. Because if there was a forearm and a bicep placed across the neck, the jugular vein and carotid artery may be compressed, which we're concerned about, but the airway might not be involved, and that does not mean that there wasn't strangulation. So we're really looking at this perspective. We also, at our level, we perform a danger assessment 5. We are already going through so many things at night with a patient. We do not really need to go into a full 25 danger assessment. This is where advocacy will complete the full. We need to give people kind of that rest cycle if they haven't had it. So there's a lot to these exams that you know, we don't want to overwhelm anyone, but we also need to understand, is there risk? Is there danger that we need to be, are you high or low risk, you know, based on this tool? And then hopefully they'll be able to get their full danger assessment. And then I already kind of talked about some of these cases or those statistics. I just want to pause. Does anyone have any questions on the medical exam?
If you have questions, you can unmute yourself or raise your hand, or even put it in the chat.
Is this helpful, Joy? Is there anything more you want me to cover before?
No, I think we're doing good, and I don't see any hands going up. So you're doing great, Michelle.
Okay. Well, so how do you get to us, right? Like, how do you call and how do you ask these questions? So for Palomar Health, here on the screen, if you could still see my screen, right? It's still showing.
Yes.
You've got a 24, I keep 3 nurses on call 24/7 to answer your questions. And so if they ever don't know, like, a nurse will always be on the other end to help answer a question. And for children, you know, same. So this is the daytime hour number, the 2150, and the 888 is our after hours number. And if you ever have a question relating to children for the South County, or, you know, want to talk to a child abuse pediatrician, the Chadwick Center, Rady Chadwick Center also has their number. And, you know, we work really closely together with Chadwick and Palomar. And our team actually goes out and performs the exams for them at night, weekends and holidays. And so even if one of the teams were called, you know, we always work together on what's the right place to go, how do we answer those questions. And so, you know, keeping that a little bit up on the screen. And we have about 20 minutes left, Joy. Is that, do you want me to?
Yeah, you're at 20 minutes.
Okay.
I haven't a lot of questions, so if you want to go through, if I get another question, I can just let you know.
Okay, perfect. I wanted to share, you know, I know this is really heavy, right? It's like a really heavy topic, but how do I share, like, how do we kind of close the loop on child abuse and sexual assault awareness month, and also turn it back to honoring all of you that are doing this work? And I have a video that I made a few years ago that I'd like to share. The animation was brought, was developed by a teenager whose mom also does this work. And I wanted to share this with you guys in kind of closing, but also then allow just a space, an open space for any conversation. So let me just, give me 1 second. I gotta get back to the other one I was in. Sorry, Joy. Just give me 1 second. I'm getting to the other PowerPoint. Here we go.
You're
Okay. And then I'd love, like I said, you know, however whatever that means, to be able to have, if you want to have a call, you know, on strangulation, I'm happy to come back, because I think that would be like a more in-depth, or you guys could, you know, maybe come to the CARES training, which we offer CEs, CMEs for that training too. Let's see. Okay, come on, from current slide. There we go. So this last video, I want to you know, go by saying that you all do such important work. And, you know, it's not about disclosure, it's about trust in the system. And where it starts is us learning about what we all do and how we trust each other. Because you might be the one having that conversation with the person, and it's okay to not know the answers. I don't always know the answers, or especially around advocacy. So this is where I lean on our partners. And if there is a question, I can call and say, or I can tell that patient, you know, I don't know that answer fully, but guess what? I have somebody I can call if you're okay with that, and maybe we can talk through it, or you can talk with them. And so it's like, how do we can work together, right? It's that link in the chain, and not one of us is, you know, I view us all as partnership. No one, I don't see us as all, we all have this different role to play. But I just want to honor you all in what you do, and honor the time that you've taken today. And this video is a little, you know, we haven't been able to get together and have as many photos as we want over the past couple of years, but I think that you'll get the intent. And I wanted to finish by saying that it starts with us. It starts with us as believers, as hope, you know, providing hope, talking about it this month. And I really want to thank the Strong-Hearted Native Women's Coalition for having this conference annually, continuing to invite me back. It's just such an honor to be here today, and I want to end this presentation honoring all of you with this video.
You are not hidden. Never been a moment you were forgotten. You are not hopeless. You have been broken, your innocence stolen. I hear you whisper underneath your breath. I hear your SOS, your SOS. I will send out an army to find you in the middle of the night. It's true, I will rescue you. There is no distance cannot be covered over and over. You're not defenseless. I'll be your shelter. I'll be your armor. I hear you whisper underneath your breath. I hear your breath so wet, your breath so well. Send out an army to find you in the middle of the night. It's you, you. Never stop reaching to reach you in the middle of you. I hear the whisper underneath your breath. I hear you whisper you have nothing left. I will send out an army to find you in the middle of the darkest night. It's you. Never stop to reach you in the middle of the heart. But it's true. You. Oh, I will rescue you.
Thank you, everybody, for attending today. And hopefully you were able to learn something. And thank you so much for having me, Joy. I really appreciate you. And
Thank you for joining us again, Michelle. It's I think I learn something every time. So, and you know, what you guys do is not easy. Another comment came in, and it was just a suggestion. And I know this was pictures of your old space, but they suggested possibly placing some plants in the interview areas.
yeah, I think it gets complicated working with potential allergies in healthcare space. So that's something that I just would want to make sure that you know, I acknowledge that, definitely. And I think in the new space, we might look at how to have areas of mindfulness that people can go to and know what is there. We're also looking at pet therapy. We're looking at, you know, integrating as many, you know, how do we look at providing access to more robust therapy, and also just modalities, cooking, looking at job replacement. So, and we'll be in the new Family Justice Center, which I think will have a lot. And I wanted to say, like, our old space, you know, that was what we had to work with, and we did mess. I think it was too small to have plants, but maybe in the new space too. Yeah. But thank you
It
for
was
that.
really, yeah, that was just typed into the question area. So you guys are not located physically at the hospital, you're off-site.
Correct. Now we can go to the hospital, like our medical team can go to the hospital if somebody's unstable or unable to be discharged. We can go to any hospital in the county. Because we would perform that part of the exam, but so if someone's in Tri-City, if someone's at Scripps, and ideally exams should not happen in EDs because it's not a good place, a trauma-informed space. But if somebody's medically unstable, if there's something going on, well, either if there's ways we can help transport them, because as you see, we have all of our equipment, we have the setup, the lighting, the evidence collection, it's all, that chain of custody is really better at an outpatient center. But if they cannot get there, we will go to them. And so, you know, you have to be flexible as well. So we, you know, because we do not build it, there's no need for us to build a patient's insurance. We are we're kind of in these private outpatient centers. So as you know, when somebody maybe goes to the hospital, they have to check in, register their insurance. They can't just walk out. They have to have a medical screening. They have to talk to a provider. And that sometimes triggers, and it may be that they just want an exam. And there's, without strangulation, without strangulation or major trauma, there's really no reason for someone to go to an ED, because we'll do all that, and we're not then billing their insurance. We're not exposing their visit to any potential holders. It's really, and they're not going to get a bill for it, right? Because in California, that's one protection, is it's actually illegal to bill a patient directly or indirectly for the medical evidentiary services. So,
Oh, wow.
yeah, it's, and that's why, you know, in other states there may be like, so law enforcement does pay for these exams and authorize it, but that's also a way to protect them so that they don't have to pay for it if they're unfunded. Now we're not giving them a whole bill, or if their perpetrator is their insurance holder, we're not now tipping them off. You know, there's just a lot to think, like, things to consider. So if I think from the community advocacy perspective is, what would they need, right? And do they need, if there's strangulation, if there's major trauma, then they may need to go to the ED, but we also can kind of talk with them and assess with them. And then they, you know, access to crime victim compensation for reimbursement, you know, all of those things kind of get put into place.
Yeah, that's a lot.
Yeah. Yeah, and I think this is why, you know, sometimes it sounds very great to, oh, I want to be a forensic nurse, I want to be, you know, but the responsibility and complications that come with it, and this is why when San Diego having really this core process is really important, because there's a lot of things that get, you know, when we go in to do a case, we don't clock out till that case is done. So when we respond, we don't turn it over to the next nurse. So if we're on call 7 a.m. to 7 p.m., we get called at 5 p.m., we go in to do that case, that's our case. And we might be there till 11 p.m. to finish it. We don't pass it on. It's our case. So it's, and it takes a lot of training, and it's a lot of unique things that go into this, because ultimately we have to have all that infrastructure in place, because if this does go to court, which sexual assault sometimes doesn't go for a while, all of those things need to be put in place, like that our chain of custody, our neutral position, our standardized processes and forms. But, we don't take the approach of this is going to court. It's really about that medical care, and we're conducting the exam with consent as part of the process. And that will allow that patient the best opportunity either way, right? And so we're just that link in the chain. Because they may decide to not participate, but then if they change their mind, now they've had at least a fair chance with collection, with that history, with that documentation.
Okay.
Yeah.
Wow.
Yeah.
Well, thank you for joining us, and thank you for what you do.
Of course. Well, thank you for having me. I appreciate you and all you guys do, and all the partnership over the years. And please let me know if there's anything more you'd like to learn, or if there's any I can have, anything you
Well,
need.
I was thinking that maybe if it's up to you, but since we post these, if you wanted to do the strangulation piece on Friday to
Oh,
go with,
yeah,
that might be a good balance so that everybody can see both.
sure. I can add that into the, so I can add that into there. I just wasn't sure, for time and stuff too, because it can take a while, but if you want me to add that piece in, I'm happy to
I
do
don't
that.
know how big it is or how small it is. I was just thinking, because you had asked, which.
Well, I can put the strangulation addendum in there, and like you can be available to your participants. No problem.
Cool. All right.
Yeah. All
Well,
right.
if
Thank you.
nobody has questions, we will let you go and get on with your afternoon, and we'll see you back here on Friday morning. All right.
Thank you. I think I just say stop sharing screen, and then.
And you're good.
Awesome.
All
Okay.
right. Thank
Thank you. All right. Bye-bye.